Hello, good evening, everybody. Good evening, doctors. On behalf of Hetero Healthcare, I, Dr. Prashant, welcome you to this webinar on PPH management then and now. Doctors, as you know, in Hetero, we market products in multiple therapy areas like gynecology, dermatology, pulmonology, ortho, etc. We have a very strong R&D background, doctors, and we try to develop products keeping patient benefit in mind. Our endeavor is to improve patient compliance and ultimately clinical outcome. We have developed NSAID patches, rivastigmine patches for patient compliance. Gynecology, obstetrics, and IVF is an important therapy segment for us at Frenza. Apart from oral tablets like Didropal and Milotin, we also market products for vaginal health, Feminora, Pelitra, and recently we have marketed a vaginal film under the brand name Celera. It's a lactic acid film. Recently, we have launched introduced a product, carbetocin injection, under the brand name Carbiact. The Carbiact, we all know carbetocin is recommended for PPH management, prophylaxis of PPH management. And to speak more about PPH management and use of Carbiact, we have Dr. Vidhya Bandookwala with us today. Madam Dr. Vidhya Bandookwala is MRCOG, DNB, DGO, and FICOG. Madam is founder member of Female Pelvic Pain Association, core member of Global Interstitial Bladder Pain Society, managing committee, associate fellowship gynecologist. Current and Madam is attached as director at Touch of Joy Women's Clinic and Fertility Care, consultant at Saket Maternity and Nursing Home. We have the pleasure I have the pleasure of inviting Dr. Vidhya today. Madam, good evening, welcome. That's all yours.
Thank you so much. Thank you, Dr. Prashant, and thank you for the kind words. I also thank at the outset with the Hetero Healthcare, one that you enlightened us with the products and the importance of your products with our obstetrics, gynac, and fertility. So thank you very much. And I think without wasting, let's begin our session. I hope I'll be able to do justice to this.
We are sure about it, certainly.
Yeah. So we all as gynecologists, or I would say an obstetrician, we all know that the most daunting and the most nightmarish situation is when we have a delivery. It's not just the delivery of a baby, but it is the aftermath of that. That is when a baby is born, and then what happens later can become absolutely a daunting situation, because this is such an unpredictable and unfortunately it can happen in the lowest risk of patients. So we as obstetricians need to be always aware of these situations and be prepared, because this is so unpredictable. It can happen at any situation, any place, anywhere, anytime. We can have a delivery where everything has gone so well, baby delivered well, and suddenly within minutes, we know there is a situation that needs to be tackled, and it needs to be tackled in a rapid way, not just about, looking and assessing and, assuming that things will go well, praying to God that, oh my God, just be with me and all that. No, these situations need to be tackled, and we need to be smart. And I think situations like this have to be prepared. And I am thankful to Hetero Healthcare, because this kind of drills are so important for us. So let us just have an overview of the PPH protocols that we have seen. So what do we normally see in a patient who's just had a delivery? We normally see that, the patient has delivered. We have a little delayed cord clamping because we want the baby to receive that extra blood. So to prevent anemia in the newborn, that's the newer aspect from the pediatricians now. But meanwhile, what are we preparing? We are already preparing for the active management. Why was active management bought in the first place? Because then, as we now have this session as then and now, what happened then? Then it was, they used to wait for the physiological aspect of the placenta separating and then the placenta being expelled. But by then, the mother would lose a lot of blood. And that is when, obstetricians came together and realized that why should a woman bleed and waste that blood when we can take care of it. And that's when the active management came in place, where they decided that with the delivery of the baby, at the delivery of the anterior shoulder, why not give uterotonic drugs that can already start the process of contraction and retraction. And meanwhile, while we delay the process of cord clamp, we give enough time for the uterus to already start the process. And hence, while we deliver the baby, we clamp the cord mostly after a minute. That is the newer version. We then wait for the uterotonics action, and we actually can also do the cord traction, the controlled cord traction, which we know that, lift the fundal part and slowly deliver the placenta. Now, this aspect of managing the third stage has lessened the burden on the woman in the way that we are halving her blood loss by 50%. So can you imagine those days where the woman would bleed unnecessarily? Today, we are already not allowing that part of bleeding to happen. We are saving her from blood loss. Also, in a place like India, we already are a developing country. We already know that our women are already anemic. We have women who are sometimes 8, 7 grams, who have not, even reached the antenatal care and suddenly have come and delivered with us. We have no clue. We just get a CBC while she's delivering, and we actually see that her hemoglobin is just about 8 or 9. So in such situation, an active management is the thumb rule today. So what do we understand by PPH? Do all the women have PPH? No. So we have had a criteria that when there is a blood loss of more than 500, that means this woman is in high risk. And we have to now start acting on that assessment and response. So 500 is given as the upper limit. Usually even 500 is on the upper side. Here we have put 500 because we know that the body can compensate. This is the compensatory phase where we know that this woman can compensate and her hemostasis will take over. But what happens when she goes beyond 500 ml? That's when we need to start realizing and act upon the situation. So the upper limit post a vaginal delivery is 500, whereas in a C-section, it is taken up to 1000 ml. So what do we see in a normal postpartum period? That means after the placenta is delivered, we usually see that the uterus is contracted and retracted, and we can feel it like a hard ball. Whereas what happens if the uterus is not contracted or retracted? We see atonicity. Just imagine this complete atonicity, and we actually can feel the fundus right above the umbilicus, filled with blood. Now, this is where we know that, yes, this is a cause for the bleeding. This is atonicity. Now, what normally happens? PPH is common and can occur in, I just explained that it can happen with any woman. It can be a primary, a multi, a over-distended uterus with multiple pregnancy. It can be a placenta that is low-lying. Every such patient, of course, are high risk. So what can we do? We can always, in the antenatal period, we can decide who can be in high risk and who is a low risk. Of course, it does not 100% let us know that the low risk can never become a high risk. The low risk can definitely turn to become a high risk in the delivery, in the labor room. But what about those who are already in the high risk? Yes, we can categorize them in the high risk category, and we are prepared. We know that this woman may have chances of having a postpartum hemorrhage, so we should be prepared. We should be ready with her hemoglobin raised before in the antenatal period. If a woman is already at 9, we are just so fortunate that we are in an era where we have the infusion of iron. There were days when we used to give intramuscular iron with reactions and with women tortured with the injection. But today with the infusion, the rate of increase of the hemoglobin is just wonderful. So today we must identify these kind of women. We must prepare them for the delivery by raising their hemoglobin to a decent level of 11 and plus. Now, what do we see in postpartum hemorrhage? What are the causes and what are the etiology? We'll come to the next. But unfortunately, just see the picture. It's almost 35% of all our maternal death that we see. It is one of the direct cause of maternal death. And it is almost to the tune of 35,000 women, 35%. And in the developing countries, we have 240 per 100,000 live births compared to 16 in the developed countries. So can you imagine the difference of 240 and 16? Where are we? We are here at 240. Why should even one woman die of PPH in today's era when there is so much? We are coming to artificial intelligence. How can we expect that one woman died of PPH when we could save her? So these are the drills that can help us. You know, if we have this drill way again and again, I'm sure PPH is not a topic that has not been discussed. Every month, I'm sure, or every week, there is a drill that happens, but it helps us. It tunes our brain to understand what a step can be taken when we fall in this situation. I've actually seen people, get nervous, shiver when they see PPH, because it's so easy to discuss it, academically have CMEs. But when you actually see a woman bleeding at that point, any and every person can feel fearful and not be able, they just have a brain block. They're not able to function. So at this time, as a obstetrician, you must be able to call for help. The first thing that anytime we see a situation like this arising, please do not get into ego issues. Just be prepared to call for help and call for as many help as you want, starting from your colleague to an anesthetist to even your staff, because you need more number of people. You will need blood products. So you should be prepared for such a situation. What about the global PPH incidence? 14 million women suffer from PPH. We all know the incidence of PPH is almost 2 to 4% after a vaginal delivery, and it can go up to 6% after a cesarean section. So it's not that we can assume that every woman whom we deliver will end up in a good situation. No, we should be prepared, and we should know these consequences, the sequelae after the birth of a baby. We should be prepared for that. What is the PPH in India? Let's just look at the Indian scenario. 38% of the maternal deaths are due to PPH. Can you imagine 38%? 25.7% of the global deaths take place. In fact, I just went through the FOXY guideline and I got to know that we contribute to 12% of the PPH deaths in our country alone. So 12% is quite a bit. We cannot just take it down, looking and just saying, oh, we are 12%. No, we need to decrease, and it can be done by each of us contributing in our own way. We need to own our mistakes. We need to own our understanding, and we should be prepared. Now, what can happen? The impact of PPH, of course, the impact is so much on the woman and the newborn. It also reflects on our healthcare. It also reflects on the family. Imagine losing a mother at the time of a happy moment is so disastrous for the family, for the healthcare person feeling helpless at that situation, and the newborn being born and being orphaned at that time. So I think it's time we start looking back at what we missed and what we can do today. So what happens when we get a PPH patient? Of course, there is an increase in the hospital stay, because this patient will probably need an intensive management. She will need a dependent unit, a high dependency unit, to be monitored till she absolutely feels fine. So there is a long stay. The higher inpatient mortality, of course, it will be a mortality, because if the patient is losing blood and we are not able to assess the loss, we are not able to give her the fluids, the blood that she will require at that moment and stop her bleeding, she is going to end up with a severe PPH. And before we realize, sooner than later, we know that she's no more. So there is a high rate of mortality, and we need to understand that. What does it do? It majorly impacts on the life and health of the affected and their families. Yes, it does. It is so easy to speak, but when somebody goes through such a situation, it is very, very difficult. long-term psychological impact. Now, what can happen if a woman has undergone a PPH, and the whole impact of her visually, seeing people coming in, getting blood transfusion, these women go into depression, they can go into psychosis, they can go into mental instability, and this can definitely affect her newborn and the family. So it has a long-lasting impact, and we need to understand that part of it. Now, coming to the etiology, how do we analyze why a patient had this kind of episode of bleeding? So the first and the most important is the uterine atony. It contributes to almost 70 to 80% of the hemorrhage. Then we have the coagulopathies, the thrombin, the 4 T's that we are always looking at. The second is thrombin. The third is trauma, because any kind of delivery, we must assess that there could be a traumatic, where there are some obstetricians who do not believe in giving an episiotomy. They can have a tear, or sometimes we know everything is going, we give a good clean cut episiotomy, but there could be a shoulder dystocia, there could be an obstructed labor, there could be a prolonged third stage, and the need for an instrumental delivery. All that can contribute to lacerations, or she could end up having a cervical tear, or sometimes the tear can go right up above. Or in a previous C-section who's come in labor can have a rupture. So trauma also contributes, and it is almost to a tune of 10% plus. What about the tissue? Tissue is what we look, the placenta. Whenever we deliver the placenta, we must make sure that we see the completeness of the placenta. Are we missing any cotyledon? Sometimes a succinturate lobe can be still stuck up in, and that could be a cause. So very important is to check if by any chance, sometimes we reach before the patient has already delivered and the staff has said, keep the placenta has expelled and everything is fine. No, I think we must ask her to open the placenta and we must see for the missing cotyledon, because here we probably miss a big thing. You see, if we miss on this, we will land up in a bigger soup. So always make sure that you have monitored and assessed the placental completion. And if there is a risk factor which we have antenatally seen, then we must be prepared for this. Going to the next slide, as I discussed, that atonicity is the failure of the uterus to contract or retract after the birth of the child. And the commonest reason is when we see the lower segment. We all know the segment below, that is the lower segment, the retraction is very poor. So imagine a placenta being there. The sinuses are opened as soon as the placenta is separated. So we have to be prepared in such cases. Over distension of the uterus with multiple pregnancy. Previous history of PPH increases the chance to almost 15% in the next pregnancy. So even in the history, I think we as obstetricians normally never ask the patient about her previous birth. We never bother to ask. We only ask, did you have a normal delivery? What was your this? But we must go a little deeper in understanding what kind of delivery she had, whether there was increased blood loss. I'm sure today our women are quite educated, at least in the urban population. Of course, the rural population may not be able to give the history, but even a uneducated girl or woman can give us an understanding that what happened after she delivered, if she's ever had a PPH. So we have 70%, which is contributed by the atonicity. Then we have 10%, which is because of the tissue retain. We have the trauma, which is almost to 20%, and the coagulopathy, which is 1%. But of course, we cannot take it lightly. We need to work on even the 1% that is there. So again, when I say that when we are assessing for a woman who's having a bleeding more than 500 ml, there is a visual estimate that we should be prepared to know. Always, whenever a patient delivers and we feel that she's bleeding beyond our understanding, please be prepared to call for help. Even though you know that she will be okay in few minutes to a half an hour or immediately, it's always better to be prepared for the worst. So assess and visual estimate is very important. Don't underestimate, because then you're delaying your diagnosis, you're delaying the call for help, and the whole process will be delayed. So always assess. And the first thing that after you deliver the placenta, keep your hand on the fundus, see whether it is retracted, see whether it is contracted, feel whether it is feeling like a firm, hard ball. Even then, if she is bleeding, you know that there could be trauma. Open the vulva, visualize if there is any bleeding coming from the lower part. And if you feel, yes, she is traumatic, call for the anesthetic, shift the patient to the OT immediately. And with a good light setup, you must explore and see if she has any kind of trauma that can be immediately taken care of. Again, we come to the tissue part where we see retained placenta, which means that either the placenta has not delivered even after giving uterotonics, or if you're looking for the physiological management of third stage. We look at multiple pregnancy. We look at failure to progress to that is the prolonged and obstructed, prolonged third stage of labor, episiotomy that has been, extended posteriorly, going up to the rectal, almost like a 4th-degree tear. These kind of episiotomy will also bleed. Then you have to understand that today we cannot miss a placenta accreta. With our ultrasound today, we are able to understand the location and the placental anchoring. So we cannot miss a placenta accreta. And these kind of cases where we know the woman has a placenta accreta or percreta, we must never deliver such patient in a small nursing home unit. These should be categorized as high risk, and they should be delivered in a tertiary care center, keeping everything ready, prepared for the worst. And a high risk consent taken from the patient and the relative are making them understand that she may land up with an obstetric hysterectomy, she may need embolization, she may need a lot of other things. So these kind of briefing is very, very important with the family and the patient herself. Pre-eclampsia, again, here there is the thrombin part where 1% is contributed, but again, it will create problems. So we should be prepared for this. Previous PPH, as I said, that it is 15% increased risk in the next pregnancy. Again, we know that relaxation of the uterus is commonly seen in general anesthesia, though today we very rarely use general anesthesia for a delivery. But yes, in certain cardiac patients, we do prefer the general anesthesia, and we need to even brief our pediatric colleagues too. Fetal macrosomia today having increased number of gestational diabetes, we are getting big babies and they could over distend the uterus and lead to PPH. And of course, the perineal laceration that I just spoke. So we are looking at low risk population having vaginal birth. Most women developing PPH have no identifiable risk factor. I think this is something we should drill in our mind, that nobody is a low risk once they are in the labor room. They are all high risk today because every woman is now wanting 1 or 2 child, and she wants to have it in a very beautiful way. So we should be prepared to create an environment for her to deliver in the right place. And we should be ready to accept challenges in the delivery room also. Now, how do you categorize? As I told you, what is the upper limit that we have given for the vaginal delivery and an upper limit for the cesarean section? So here it is. They have now divided into minor and major. And then, of course, the major is divided into moderate and severe. So we look at 500, where we know that the body can compensate and allow the patient and her vital signs to be within the normal range. But what happens once she crosses the 500 ml, then the decompensatory phase starts. And that's where we need to work on the patient, assess her completely. As I said, the 4 T's, find out which of the 4 T's are, applicable in her case. Be prepared for help. Call your anesthetist, call your colleagues, call your staff, call one person who can note down all the sequence of the events that are going to go around in the labor room, or if the patient is shifted to the OT, or in the OT with the C-section happening. So anything that goes beyond 1000 ml cannot be taken lightly. This is where there is the moderate PPH and the severe category going into a complete non-reversible. So don't wait for the non-reversible process. Do things right at that time. And what are we looking? Again, moderate is when you have a loss of more than 1,000 but less than 2,000, and severe is when it is beyond 2,000. I'm sorry, I'm giving a lot of briefing on PPH, which all of us know, but the more we speak about it, the more we start understanding the depth of it. So what are we looking at PPH? With the compensatory process, 10 to 15% of that. What do we see in the blood pressure? There is no change because the body is compensating. What do you see? The mild signs we already see is we always see for the pulse rate. We see palpitations. We see that the patient may feel a little dizzy. But what happens when it goes beyond 1,000 to 1,500 ml? That means the loss is beyond 15 to 25% of her body blood. There is a slight fall in the blood pressure. We get a systolic pressure of 80 to 100. What do we see in the patient? She's feeling weak. She's sweating now. So make sure that when such patient starts bleeding, keep her in a warmer environment as compared to the high AC that is there in the labor room. Again, tachycardia is commonly seen. It gets more worse. The pulse rate can go beyond 120. And that is where we identify that things are going from mild, may go to the moderate category. Again, here there's a 25 to 35% loss of your blood volume. So imagine what happens. There is a decrease in the systolic pressure even further down to 70. Imagine 70 is what we look at diastolic. We are now looking at systolic. What happens? The patient starts looking very restless. She starts looking pale and she can go into acute kidney injury, and that can give us oliguria. So I will get back to what we can do when we see a PPH patient. But what happens in the severe care category? There is a profound loss, almost systolic 50. We may kind of lose this patient. She will start showing air hunger. She will literally be in a collapsed, semi-unconscious state. She will go into complete kidney damage. That means that acute injury has already set in and she's now in anuric state. Now, what is our role as an obstetrician here? Do we want to see our compensatory phase going down to the severe state? No, I don't think. We must not allow from the mild, we should reverse it backwards. We cannot allow it to go forwards. So what do we see? We see abdominal tenderness, circulatory collapse, increased abdominal girth. In atonicity, we see the fundus right above the umbilicus. There's a complete loss of the uterine contractions. There's maternal tachycardia, and there is continuous bleeding, vaginal bleeding. Now, as I said, diagnosis is nothing but your own assessment, your visual estimation of the blood loss, which only an expert obstetrician will know. So always make sure, whether you're in a private practice or you're in an institute, do not let your juniors or subordinate take over a delivery. Every delivery is precious today. So let us understand that part of it. So rapid assessment of the patient status. When you realize that the bleeding is not normal, it's more, then we must start assessing. Initial evaluation is very, very important. Presence of tachycardia and hypertension, assessment of the vital signs and blood loss. What is the next step? Examination. So you must, once you're assessing, you must rule out the 4 T's. So you assess the complete genital tract. If you feel that the uterus is well contracted, you feel that the uterus is feeling like a hard ball, but the patient is still bleeding, always rule out a genital tract trauma or a hematoma. So it can be revealed or it can be a concealed form also. So you must rule out lacerations, you must rule out hematomas, and in a case of previous surgeries on the uterus, she could have had a myomectomy, you must rule out a uterine rupture. Manual examination of the retained placental tissue. If you realize that there is a missing cotyledon, put in your hand and feel for the cotyledon and try to remove it. Assessment with the bedside ultrasound. So if you have an ultrasound and you feel there is an incomplete placenta, you can definitely use your ultrasound to understand and realize that there is a cotyledon there. Evaluation of uterus to check if there is. So if you can't feel the fundus, you must rule out an inversion at that point. What can you do immediately? As I said, immediately there should be a call, a response team should be prepared. And what is the first step? Secure the veins. Immediately, a high bore vein flow should be put in. Remove the blood for the blood works. Make sure you cross match at least 4 units. Even if you feel it is mild or moderate, let there be a cross matching for 4 units. Be prepared for that. And then you can start the replacing the volume. Whatever loss she is having, try to replace till there is blood available in your hand. So the overall replacement should be almost to the tune of 3.5 liters. So you could divide it by giving her crystalloids, which is almost 2 liters, and almost 1.5 liters of colloid. Now, this will keep the volume of the body, and that is also very important. Send her blood for the basic hemoglobin and hematocrit values. Send for electrolytes, send for renal function, liver function, and the coagulation profile, and make sure a fibrinogen level is mentioned there, because we need to know that. These are the process that will tell us how to replace. And if you and if you are in an institute, make sure that a hematologist is also involved, because they can help us and guide us in what kind of fluid management is required, what blood products, including a cryoprecipitate, an FFP, a packed cell, what can be given, and what is the ratio that can be given at the same time. So this is very, very important. I think before we start with understanding and diagnosing PPH, the minute you understand that there is a PPH happening, do not waste your time. Make every minute valuable to the patient and to yourself. Make sure that there is one person who can, give us a flowchart of what are the events that happen, because today we are also medical legally bound. We should not forget that while we are doing good work to the patient tomorrow can get back to us and create a problem. So make sure that there is some person who is writing down the sequence of our, flow of helping the patient with all these things. And ABCD, make sure there is an airway. Give her almost 10 to 15 liters of pure oxygen per minute, continuous oxygen. Monitor her vitals. In mild cases, or maybe in the early moderate cases, you can every 15 minutes. But if there is a loss beyond that, make sure that there is a continuous monitoring of the blood pressure, the pulse rate, the respiratory rate, so that you are sure how things are going. Make sure the bladder is empty. If you have an instrumental delivery, if you have a bad delivery where there was shoulder dystocia and the baby came out with a lot of difficulty, you must always empty the bladder, because a full bladder can also disturb the uterine contraction and retraction. So always make sure, one, it will help in the contraction and retraction of the uterus, and also at the same time it will help us to monitor the kidney function with the urine output. So that's very important part for all the youngsters who are in the obstetric practice now. So PPH is diagnosed by visual estimate of blood loss after delivery. That is what I've been telling, and I think all of us know it's not some rocket science that we are talking about. Again, as I said, it could be revealed and concealed. Where do we look at concealed? It could be a uterine rupture in a vaginal delivery. It could be a high hematoma at the fornical tear going up to the broad ligament, or it could be a hematoma that's forming inside. So these are things that we need to pick up and understand. What is the changes that we see? We see that there is tachycardia, pulse rate is just going high up. BP may increase as a compensatory phase and then start dropping or falling. So systolic pressure should be monitored. Flabby uterus in atonic. So, every time that we think of PPH, please think of atonicity as the first thing, because that's the major cause of the PPH. Now, what are the challenges that I think we know that don't delay the diagnosis. It's better to overreact than to underplay the game. So it is better we realize that there is a chance that this woman would end up, and we must be prepared for it. Many cases of PPH occur without any identifiable factor. Visual loss, as I said, don't underestimate. It is better to overestimate. What are the complications? I think I've already spoken. What is the impact is after a bad severe or moderate PPH, what happens to the woman? She may go into postpartum depression, and it's not easy to take care of such women, because she may not be able to handle her newborn because of the psychotic tendencies that they have. They have an aversion to babies. She can later on go to the Sheehan syndrome, where anterior pituitary ischemia is there, and she may not have, she may have a long amenorrhea, and that needs to be tackled in a different way. Because of the anemia, she will be so fatigued and exhaustion that she will not be able to do her day-to-day, management with her newborn. So she won't enjoy her days with the newborn, where every mother is actually looking forward to do that. What happens? There is a blood transfusion and number of blood transfusion, and their sequelae is also there. It's not just giving them blood at the moment, but the later sequelae of heavy flow, heavy transfusion reactions in the form of respiratory distress. So we need to look into all these. What happens? There could be chances of myocardial ischemia. There could be dilutional coagulopathy, because we are just, increasing her volume without even knowing what repercussions can happen. And that is where we need an intensivist, we need a hematologist. So it's always a multidisciplinary task when it comes to PPH. Do not try to be a one-man show. You cannot be a one-man show in these cases. You must involve as many experts who can at the moment help us to think. It's not that we don't know how to manage a PPH, but if we have a patient who is our patient, you can go into a brain fog. You will at that moment not know what to react. So it's very important that you involve as many people who will be helpful in that case. And of course, the last, which none of us would want to, is the death of the mother. Now, what is the stages of labor? I've spoke so much about PPH. I'm sure everybody of you all must be wondering why she's stressing so much on the PPH. But the understanding is so important. Let's look at the stages of labor. We all know from the time the patient goes into labor to the delivery of the baby to the delivery of the placenta. 3 stages are so important. Though the stage 1, the longest stage of labor, what do we look at? We look at contractions and the dilatation of the cervix and the descent of the station of the head, right? If it's a vertex presentation. What is the second stage? Now, this is when the cervix is fully dilated until the birth of the baby, right? We all know this. And the third stage is when the baby is delivered, and then there is the contraction and the expulsion of the placenta, which is through the genital tract. As I said, then and now, what happened then was they were all physiological management, conservative management, no, do nothing, just wait for the natural birthing process. But what happened is they all realized that the woman was losing much more blood and landed up being anemic, being fatigued, not able to do her day-to-day activity. So every obstetrician realized that there was a conundrum, and then things happened that active management became the thumb rule for third stage of management, because they believed that why do we wait for unpredictable situation? Why can't we predict it and help the woman beforehand? And that is why there is a third stage labor could be managed with active management, not trying to wait for the physiological management. I think whoever is listening to me will second on this, that today we do not waste time and wait for the third stage of labor. We actively manage it and cut short the whole process, and so help the women in saving 50% of her blood loss. Now, how do we do this? So we are so blessed that we are in an era of newer inventions and newer products or newer molecules coming into the market. And today it's time for a change. I mean, yesterday I was just witnessing that we are from a 50-over match, we have come down to a 20-over match. Nobody ever thought that the 20-over match would take over the country to another level, but we did. Yesterday we witnessed that people actually waited midnight plus for the decision of the match to be taken place or no. So if we are so prepared for a change, why not prepare for a newer molecule? So this is where I'm going to speak now about. what happened in the third stage is, as soon as the baby delivered, mostly when there is a delivery of the anterior shoulder, we used to inject the uterotonic agent, and the most preferred one was oxytocin, because oxytocin had its action is immediate and it gave a much better response, and it had very few side effects. Of course, if it is given in a higher amount, there are other side effects that I will discuss, but the choice was always oxytocin over other uterotonics. Delayed clamping for 1 to 3 minutes and perform the controlled contraction if required. Assess uterine tone immediately to ensure. So we all know this, the third stage of whole thing. And what did the WHO do? It highlighted the use of uterotonic as the most important part of active management of third stage. I'm again and again stressing on this point. So how do we prevent? Now we are coming to the actual topic of discussion, which I'm here for. So one is the approach. It's very important that how we approach such situations. Prevention should start from the antenatal care, where we categorize the low risk and high risk. Of course, as I said, there is no low risk. Even a low risk can become high risk within seconds to minutes. So, but there are predictions that can come up, and this is by antenatally categorizing the high risk and managing them in a higher sector, higher tertiary care centers, and being prepared for the outcome. So immediate availability of medication supplied. See, you have to have the complete checklist. You have to have the response team. You must know the massive and emergency release transfusion protocol. This is the massive transfusion protocol that we should be aware. So a hematologist colleague will be the best, bet at that point. Patient-centric recognition and prevention. Again, as I said, if there is an anemic patient, try to correct her anemia before her getting into labor. If she has sickle cell, thalassemia, all that, be prepared for that. Sonographies can help us to find out the placental location. Is it low-lying? Is there any invasive placenta in the form of a percreta? High risk. Today we have C-section patients with, 2 previous cesareans. Those are the patients who are high risk for all these kind of placental anchoring, percreta and all that. So we should be very prepared in knowing their ultrasound report and always looking at the location of the placenta. Is it anterior or posterior? And if anterior, is it low-lying or, it is at the fundal level? High-risk delivery should be performed, as I said, always in a tertiary care where there is a blood bank and there is an in-house proper service team. Intrapartum management using the always active management. Avoid routine episiotomy and instructed. So I wouldn't say avoid. If there is a need, it is better to give a clean cut episiotomy than to have a ragged, lacerated tissue after the delivery. Measure the cumulative blood loss and track the postpartum vitals. So it is a simultaneous parallel thing that has to be done. You cannot say that, oh, we are seeing the blood loss and we don't bother about the vital signs. No, you must estimate the blood loss, and at the same time, there has to be somebody who's looking at the vitals. So it's never a one-man show. Please make sure you have enough help. Call for help loudly. Respond to every hemorrhage. So every hemorrhage should never be taken lightly. Each and every patient is precious. Every life matters. So every woman matters to us as an obstetrician. Use an emergency management plan with checklists, support programs for patients. So the debriefing has to be simultaneously with the family. You cannot be doing your, correction with the woman and not briefing the family. There has to be one staff who is briefing the family at the same time. Now, how do we practice a prophylaxis of PPH? So one is you must identify, you must plan an institutional delivery, you must be vigilant over all the third stage labor patients. Practice active management. As I said, this practice is when we do drills. CMEs like this, just listening to something going a day in and out, it gets impacted into our brain and we can work when the need comes. Examination of all the placentas after birth should be a routine. Make this a point. This has to be a protocol. whether the placenta is complete or there is a missing cotyledon. Explore the genital tract after every difficult or instrumental delivery. I think this was always taught to us as students, and I think every obstetrician, even today, having had a difficult or an instrumental delivery, will always trace the cervix and look at the vagina if there is any tear. So these practices are it's good practice, and we must go on with these kind of practices. What is the WHO recommendation of the use of carbetocin? Now we are coming to the uterotonic. So we all have known that then oxytocin was the major drug that was used, and it was used very well, and we got very good results. But we all also know that oxytocin needs a temperature management. We also know that the efficacy of oxytocin can go down if the cold chain is not kept in touch. If it is not managed, the cold chain, the efficacy of the drug is gone. How do we know? Is there a control over that? No. Today, in the underdeveloped parts of India, we sitting in metro cities can have good refrigeration and good good boutique maternal care centers. But what about rural areas, or what about even a little 3-tier cities? They may not have the electricity. There is shutdown of electricity every now and then. The refrigeration may not work. So in these cases, oxytocin efficacy can go down. Again, what WHO recommends is the use of an effective uterotonic for the prevention. Yes, of course, we have to use the best. We cannot at this time compromise even a drug. To effectively prevent the PPH, only one uterotonic should be used. Now, then we did not have a choice. And when you don't have choice, you have nothing but to make the best of what you have in your hands. So in a unit that does not have too many, you don't have too much of help and all, you can still understand. But what about centers who have the best of the equipment, best of the labor stations, everything put together? I think those are the places should not compromise at all. Uterotonics to be used is oxytocin, carbetocin, misoprostol, ergometrin. Oxytocin and ergometrin, syntropmetrin can be used. So we know that oxytocin has its role. We know that misoprostol has given its best, but there are certain side effects. There are patients, there is increase in the body temperature, there is shivering. Sometimes in ergometrin, it is restricted in a patient with PIH, high blood pressure, or a cardiac patient. A combination of all this can be given. It's not that it cannot be given. If you don't have a choice, you have no choice but to use these. So what is the first choice is always the oxytocin given at the time of delivery, vaginal delivery, and a C-section where we give 5 international units or 10 international units. You can give it IV or you can give intramuscular, or in the form of infusion, where we actually have even given up to 40, 80 international units in a 500 ml. But what are the side effects? We know that oxytocin has a comparison with the vasopressin, and it can cause water toxicity. And in that, we can land up having hyponatremia, convulsions, and a lot of other things. So again, we need to be very careful when it comes to PPH management. Again, ergometrin, as compared to oxytocin, they do have a reduced efficacy, but there are chances of nausea, there are chances of vomiting, and of course, we do not give patients with PIH or any cardiac problems. Combination drug can be used, but again, they have their own set of contraindications as mentioned below. What about oral misoprostol? We do use a lot of oral misoprostol. We use per rectal and in combination with the oxytocin. So these, but what happens? They do cause a lot of nausea, vomiting, diarrhea, shivering, and pyrexia. So ultimately, if I had to be a laboring patient, I would definitely want a drug that would not give me any adverse effects. I do not want to be sitting, vomiting, retching, having loosies after our delivery, or shivering, or having an increase. So I'm sure we must respect a birthing mother. We must give her the best of what we can. And why not think of one best molecule which can do the needful of all in combination? And that is what we are looking at, a newer molecule and how to go about with that. Again, what is the most effective management of the third stage? reduce the risk of PPH through the maternal hemoglobin level lower than 9 gram and need for manual removal of placenta. Now, these are where the tissues, where there is a placenta that has not expelled out. What do you do? What uterotonics can we use at this point? Oxytocin soon after delivery, control cord. I think we are repeating this slide, so I will go. What is the treatment? Prevention, again, we just spoke about oxytocin. If oxytocin is given and the patient is still bleeding, we have always used Mithergin in a patient who's not hypertensive or has had any cardiac this. And if that also has not worked, we have gone into misoprostol, per rectal or oral sublingual. And these combination has definitely given us the best results. I am not going to say no, we have all used this drug. But again, as I said, how do we know that the oxytocin that we are giving a patient, the efficacy is at the best? Because we are not sure about it. So if oxytocin or other uterotonics fail, there is tranexamic acid. We have realized its role as an antifibrinolytic, and the 1 gram is normally given, and it is always to be given early than late. If all these measures of first line does not do well and the patient is still bleeding, then we go to the more invasive mechanism, which is the intrauterine balloon tamponade, suitable for women who do not respond to uterotonics, or if the uterotonics are not available. So again, if you are in a standalone unit, you are in a nursing home sector where you do not have too many things in your hand, you must not wait for only the pharmacotherapy. You must parallelly work together and introduce the invasive method at the same time. If you think that you are failing to even achieve in that, you must realize your limitations in a standalone unit and shift this patient as soon as possible to a higher center, keeping everything ready while transferring such patients. Use if bleeding does not stop despite treatment. So we know that if it does not work, then we need to even refer the patient. Some women still require treatment for PPH despite that. Yes, we all know that active management does not, allow the patient to just get back to normal. Some patient, 2 to 4% in vaginal delivery and 6% patient, even after receiving uterotonics, even after having a manual massage, may still land up going into the mild and moderate category, and such patients will require a better intervention. So PPH treatment may be required where no preventive agents are available or after failure of prophylactic use of uterotonics in the form of oxytocin, misoprostol. We know that prostaglandin, carboprost has been given. We can give 250 microgram intramuscular or even intramyometrial has been given, and we can give even every 15 minutes. So there are a lot of drugs that are available, and there are sometimes patients after giving all these drugs also have showed no change. These are the refractory PPH where there is no choice but get invasive and have landed up even in a obstetric hysterectomy, where even failed with the ligatory method of devascularization, uterine tamponades, and ended up being in the surgical part. These are all the mechanisms that show us, like when it is more than 2000 ml loss, that is loss of more than 40% of the blood volume. What do you get is the patient is in profound shock. Now, these are non-reversible patients and they may land up in a complete multi-organ failure, and we must never allow such, so alertness should happen when you see somebody in the mild form only. Where there is a loss of 1000 ml, you must go and assess and be prepared. This is the action time. I would not say that action should happen only when it comes to 1500. From the 1000 ml loss, the 15% loss that you see, just start the action line and be that ABCD part of the circulation and airway, breathing, everything taken in together. Challenges with the current therapies and PPH management. What are the challenges? The use of these, we all know that oxytocin has a shorter half-life. Within 2 minutes, 3 minutes, they act immediately and they can last for 10 to 15 minutes. Hence, they are usually used for augmentation and induction of labor. And even after we deliver, we have used them as infusion for 6, 7, 8 hours, where we know that it is acting on the uterus and keeping the uterus well contracted. This was then. Even now we can practice the same. Symptometrin is a combination, and it significantly increases the blood pressure, nausea, and vomiting. What the same effect is seen in the mesoprose with vomiting, diarrhea, increase in the body temperature, shivering. Again, all these have side effects of the drug. So what is the new molecule today? It is the carbetocin. And what is carbetocin? It's nothing but an analog of oxytocin. And what is it? It's got a better review. It's got a better performance because it is stable in the room temperature. It is stable in the room temperature and so convenient that it is one single dose, and we do not need to have multiplicity of the uterotonics that needs to be used along with that. And its action is similar. It helps the uterus to contract and retract, and it lasts for a longer. So it has a long short life as compared to oxytocin, which needs to be given sometimes in continuous infusion. Here it is one dose at one go at a room temperature. So we know the quality control and efficacy is well maintained. And that is the reason this molecule, I mean, today, even FOXI guideline has given carbetocin in its protocol as prophylactic management also. So carbetocin is an oxytocin. And what is the difference is oxytocin needs a cold chain. If it is not kept in the cold chain, it gets into degradation and it loses its efficacy. So the heat stable formulation of oxytocin is not available at the moment. What is the formulation is carbetocin should be previous, not now. The previous carbetocin was in the cold chain where we had to maintain a 2 to 8 degrees centigrade. But now the newer one is room temperature. It's an RTS. It's a room temperature stable formulation, which is a boon to us. As obstetrician today, I look at something that can give me more comfort, which does not need multiplicity of uterotonics to be used. Again, it is more resourceful in poor countries, underdeveloped countries. I would say every underdeveloped country should make the best use of this molecule. Why should you be in stress and pressure of every woman after birthing, landing up in PPH, even the mild form? Why should we allow? Why can't we prophylactically manage? Why can't we have little prediction? Why should a low risk woman get into a high risk category and then you act upon it? Why can't you act beforehand? So let us try and act beforehand and accept that these new molecules are only a boon to us, not just us, even the mother. Again, is stable at room temperature, has a shelf life of 24 months at 30 degrees. Can you imagine? You can keep this such a long lasting life. Avoids need of cold chain, which is the biggest, for underdeveloped country where we have a rural, standalone units in these kind of 2-3 tier cities. This is the best thing. And it is provided in a while. I think now they have come up with a pre-filled also. So timing and use, again, the timing is very similar to what oxytocin was. It is used with the delivery. I usually give it at the delivery of the anterior shoulder. Sometimes you can deliver at the end of the second stage also, before the placenta, and it helps. As soon as you give, the placenta is almost, in fact, whenever I have given in a vaginal or a C-section, I don't even need to do a controlled contraction. It is almost out and you just need to deliver. So this is the beauty of the drug. So what is it that it does? It prevents the PPH, and it is the most important part of the active management of the third stage, and of course therapeutically used for this. Now, what are the molecules again used? It's the combination of all this put together. Now let us just have an overview of what is carbetocin. We know that it's an analog of oxytocin, and with certain changes at this molecular level, we get carbetocin. Carbetocin was created by making several modifications to the oxytocin structure, and hence it has a prolonged half-life, reduces the enzymatic degradation. So hence it does not get degraded in the management in the room temperature. What I mean is, again, it's a synthetic long-acting analog of oxytocin. So if we could accept oxytocin, why not accept the daughter form of oxytocin, which is the carbetocin, a new block of, new molecule on the block. So use of therapeutic indication, prevention of postpartum hemorrhage due to uterine atony. Of course, we all know that oxytocin is used only for tonic PPH. It is the same reason why carbetocin is used. One vial contains 100 microgram of carbetocin in 1 ml. Now, we know that we comparatively, oxytocin and carbetocin have the same effects. They give the same response, but the efficacy is lost in oxytocin because we are not able to maintain the cold chain. The short life, the lifespan of oxytocin is shorter as compared to carbetocin, which can last for 60 minutes to even 2 hours after an intramuscular dose. So looking at the other part, there is a superiority in some way, not of course in all the ways, but in some way there is a little superiority of carbetocin, and hence as a newer molecule, it is always better to accept it and go on. Now, what is the mechanism? We all know receptor binding triggers, activation of the phospholipase C, generation of the second messengers, and the whole set. So single dose of 100 microgram when administered during the delivery of the anterior shoulder of the baby, or even after that, is sufficient to maintain adequate uterine contraction, preventing uterine atony and excessive bleeding, with efficacy comparable to the hours of oxytocin infusion. So the only thing is oxytocin has a shorter half-life. Oxytocin requires cold chain maintenance, which carbetocin does not. I still remember I had the thesis of misoprostol when it had come. And again, we had the same thing, that it was stable at room temperature. But of course, it did have adverse effect in increase in body temperature, diarrhea and all that. But still, people accepted misoprostol, and even today, we are using misoprostol to prime the cervix. So if we wouldn't have done that, and we would have gone back to, second trimester using the catheter and doing all that, today our life has become so much easier with the help of misoprostol, that, we are able to manage an MTP without, forcing our dilators to, dilate the cervix. Today, it is so easy. The minute you prime the cervix is almost dilated. You just have to do the needful. So there is no trauma to the cervix. So it's been a boon to us. So what is the benefit? Again, as I will keep putting forward, that it reduces the need for additional uterotonic agent. It has a longer half-life. It does not need cold storage. It has similar efficacy as compared to oxytocin. So I will not debate on the superiority, but the stability is what we are arguing on. The stability is well maintained, and that is what we need in a country like India, an underdeveloped country where there is issues with the electricity, where there are issues with refrigeration. So this is where it shows its superiority, and we must learn to accept it in that way. Good tolerability as compared to oxytocin, because in a case of moderate to severe PPH, where we will have to use oxytocin in infusion, we must note that it can lead to a water intoxication. It can create other problems. So you have to be so vigilant at that point. Whereas in carbetocin, we don't need to be that vigilant. So here we know that oxytocin, it acts, and it lasts for, say, about half-life of 3 to 5 minutes. In the intramuscular, maybe up to 30 minutes, or the 3 to 5. The duration of action is here. We know that carbetocin takes about 1 to 3 minutes, either from intravascular or intramuscular. Its action is at 60 minutes, 120 minutes, half-life of 40 minutes. So in 2 minutes, you get this action where we actually see the placenta almost separated out, almost at the perineal end, where we don't even need to do a controlled cord traction. I've actually seen this happen because I've been using this molecule for quite some time, and I've been really, really comfortable and happy. Benefits of heat stable: carbetocin is 24-fold less potent than oxytocin at the vasopressin V2 receptor. So again, here we are again superior because it is less potent than oxytocin at the vasopressin, because they have similar this. So it reduces the risk of hyponatremia. So there is a lot of good response of carbetocin when we give, when we give in patients. So here, if a patient needs an infusion with 40 plus more, we know that, we can avoid hyponatremia if we use carbetocin. And why? Because oxytocin has antidiuretic effect, and IV infusion may cause water intoxication and an acute form of hyponatremia, which can lead to cerebral edema and convulsions and a lot of other things. To date, no cases of hyponatremia have been reported in the literature of carbetocin. So another feather to its thing. Okay, so so we all believe in clinical evidence. Evidence-based practice is very, very much needed in today's era. So what is the efficacy and safety? So all these are the literature reviews, which has come. Let us see what are the literature reviews. It is efficacy and safety of carbetocin versus oxytocin, the non-inferior to oxytocin, that is a champion trial by WHO. Carbetocin decreases the need for multiple utrotonic agent as versus oxytocin. A single dose is more than enough as compared to the continuous infusion. Then there is the reduction of blood loss and need for other interventions, efficacy and safety of carbetocin, efficacy and safety of carbetocin over misoprost plus oxytocin put together. So these are the trials and the literatures that we will just review. I'm not going to elaborate too much. They're all in the net, and I think we all can just go through it. So the champion study, the largest clinical trial in the prevention of PPH, was done. And what did they find? 30,000 women across 10 countries and including India. So we have a study which has Indian ethnicity being taken care of. What was the outcome? The proportion of women with blood loss of at least 500 ml or the use of additional utrotonic agents. The proportion of women with blood loss. So this was what the outcome was studied with. And what did they find? The efficacy of blood loss more than 500 ml or the use of additional was only 14.5, and this. So as the comparison was hardly anything. Blood loss of more than 1,000 was seen in 1.5% and 1.4. Again, minuscule comparison. At least one unanticipated adverse effect was seen. So 4.9 and 4.7. So if you look at it, the conclusion is it's not inferior or superior. They're almost comparable for the prevention of blood loss. So as I kept telling you all, that there is no superiority of carbetocin over oxytocin, but the other effects, the stability that we can maintain with carbetocin cannot be challenged with oxytocin. And that is the reason we will never know what is the efficacy of an oxytocin while we are using in a patient who is going into a PPH. And that is why sometimes we need multiple drugs to overcome this efficacy of oxytocin. We may not see the effect of oxytocin. We will have to give ergometrin, we will have to give carboprost, we'll have to give transmeg and a lot of other drugs. So that can be cut short with just one molecule of carbetocin. Study design of this, what is the outcome is patients treated with carbetocin had less need for additional utrotonics as compared to those treated with oxytocin. So here we are not looking at oxytocin as an inferior drug. It is definitely a superior drug, but because of its loss in the cold chain management, it can probably lose its efficacy by the time the patient receives the drug. Single dose versus continuous infusion, and what was seen, hemodynamic effects of oxytocin and carbetocin were compared, and their efficacy was assessed in terms of blood loss and additional. So early hemodynamic effects were assessed, and the impact of blood pressure and all that over 2 hours, 12 hours, and 24 hours. And they realized that a single injection of carbetocin was found to be more effective than a continuous infusion of oxytocin in preventing PPH. So can you imagine monitoring a patient with an infusion as versus just giving one dose of the drug? How much of saving your own precious time, energy, and your the pressure of having changes seen in oxytocin. So imagine you are in a safer zone when you are dealing with carbetocin as compared to an infusion of oxytocin. Now, randomized control trial comparing carbetocin. So a lot of literatures are available in the net, and they all compare it, and the management with carbetocin is associated with greater reduction of PPH as compared to oxytocin. Again, every study has its own pros and cons. Every study has given its own review in a different way, but the comparison has always been at par. So nobody is going to question that. But as I said, the efficacy definitely maintaining its stability is very important while we use these drugs. So now carbetocin, a good alternative in PPH prevention in high risk cases. So as I said, in antenatal period, we must see the high risk category and we must make the best molecule available for that patient. We all know that the cost of carbetocin is much higher than an oxytocin, but imagine you put together an oxytocin which is not efficacious and you give multiple drugs, you end up paying exactly that much as you give for one molecule of carbetocin. So let's not, these penny wise pound foolish attitude should be given up, because in this case we are we are dealing with a life. We are not dealing with materialistic things where we are bargaining on that. So there is no question of bargaining. You have to look at the larger picture of what a carbetocin can do over oxytocin and the multiple use of other drugs and its adverse effects on the patient. So it's not just taking a drug, but it's futuristic adverse, like immediately a patient retching, vomiting, have not feeling too good. So let's give the best feel to a woman who's, just delivered a baby, make her feel comfortable. So carbetocin significantly decrease the risk of manual removal of the placenta. As I said, it almost brings the placenta out and it retracts the uterus completely over the placenta. By the time we are waiting to do a cord traction, it's already out. Especially in women with induced or augmented labor, carbetocin has 83.1% probability of being the best agent to reduce PPH, where the blood loss is around 500 ml after a vaginal delivery. The advantage of its application at the end of the third stage of labor was that it decreased the need of uterine. So as I said, it's so good that you don't even need to do a manual massage when you see there is a loss. So there is a bout of blood as soon as you give the molecule and you deliver the baby. The bout is because the placenta is so quickly separated that bout is that the blood which is formed after the separation of placenta and the retraction of the uterus. Comparison of carbetocin. So this is another study where need for other intervention, and they realized that compared to oxytocin, prophylactic treatment with carbetocin after an elective C-section reduces the need of any additional uterotonics by more, and I can vouch for that. So efficacy, again, the same study, efficacy, safety of intramuscular single dose carbetocin versus synthometrin, which is a combination in managing TERT. So all these assessments were done and compared, and I think that is when we have come forward with the molecule of carbetocin now being introduced in India, because we have now seen its efficacy, seen its safety profile, and I think it is time to accept it to our drug of choice. So let's look at reduction in PPH, blood loss, smaller drop in the hemoglobin levels and less adverse effects makes carbetocin more effective than synthometrin. So what they have seen is that there is no superiority, but the adverse effects put together is very, very less in carbetocin as compared to the other molecules. So see the adverse effects from vomiting. So we have GI, then we have the headaches, tremors, shivering. Of course, we know that carbapenem cannot be given. Misoprostol also cannot be given in patients with respiratory disorders. So all this is important while we deal with this. Carbetocin has a comparable safety. So we can give in most of the patient. We see certain changes in there is a fall in blood pressure, but they're very small fall. It's not really this. Sometimes hypersensitivity of the drug can be seen. So nobody is going to say that there is no allergic reactions to them. There can be some hypersensitive reactions, but they are very small in number. So what is it that carbetocin promises us as a uterotonic agent? One is efficacy of carbetocin was checked against the conventional uterotonic agents so it has been studied time and again with the drugs, and I think we just went through the literature, and it was compared to oxytocin, it was compared to a combination, it was compared to misoprost with the oxytocin, it was compared to argometrin also. And we all know that comparison was not that there was change in the blood loss, that we got a much better, but of course the adverse effects, everything put together, and its stability in the room temperature and its action lasting for a longer time made it a drug of choice. And that is why Indian companies also thought about it. The obstetrician in India also thought that this is, and so many institutes today have started accepting carbetocin over other drugs. So intramuscular administration of carbetocin at a dose of 100 microgram is more effective than oxytocin for preventing PPH. Its use is associated with less blood loss and a better tolerability profile. Now, this is what is very important. As I said, a birthing mother will always want to feel good after she delivers and, not be vomiting, having all the side effects of the molecules that we have been using. In women who underwent C-section, the risk of PPH was lower in the group receiving carbetocin. So these are all studies, and we've been just comparing it with all the drugs again and again. I'm not going to go on to it and elaborate. Let's see what does the guideline recommend. So we know that guidelines recognize the benefit of carbetocin. Now, what is the body? You see, the WHO, then the Canada, the New Zealand, FIGO, they've all recommended carbetocin. These are all the experts who have sat together, where I said that if they could sit together and bring in active management of third stage, today we are sitting together to get a better molecule. And we will not say that carbetocin is the best of the lot. We are just saying that its stability over all other drugs with minimal side effects makes it a more superior drug of choice as compared to others. So I think let us accept it in the right way, make it a prophylactic dose as compared, or not just wait for things to only land up in problems and then use it. So to end the session over carbetocin, let us see what are the key, takeaways. So we all know that PPH is a nightmarish situation, daunting over every obstetrician. It will always remain one, and it is the direct cause of an obstetric death in a patient. So we must decrease it. In fact, the last MMR was done, and it showed 103 maternal deaths in 100,000 live births. Even 103 is a big number. 100 women losing their life over a situation that can be taken into our hands and reversed. Why should a woman lose her life for this? So we must, decrease the MMR. We must bring it to almost the developed countries. PPH is common and can occur even in women at the lowest risk. So as I said, the risk changes in a labor room in minutes to seconds, seconds to minutes, I would say. PPH has a major impact on the lives, not just of the mother and the newborn, but even reflects on the healthcare situation in our country and a bigger impact on the complete family. So it's not a one life that is disturbed, but it is lives that get disturbed. WHO recommends the use of prophylactic uterotonic as an important step in active management of third stage of labor. The risk could reduce the risk by 40%. We know that active management then can reduce the blood loss by 50%. Imagine in that 50%, you can still reduce it by 40%. So what do you lose? You just lose 10% to 20% of blood. And we have really seen it. It's not that I'm talking, just because somebody has asked me to speak about this, but there is a superiority over other drugs. And I think it's time that if we don't voice our opinions, then we're just sitting and watching. So it's not right. I mean, today I feel that I own it. I own it to tell you all that, yes, this drug is got its superiority because I have used it. I've witnessed it. So have my colleagues who have been with me have been using this. So what is, again, carbetocin is nothing, but it is an analog of oxytocin created by making modifications over oxytocin, easily available, stable at room temperature, conveniently, it's just a 1 ml dose. It has similar efficacy, but the safety profile is much better over oxytocin. In addition, it significantly reduces the need for any additional interventions, even the need of, uterine massage is not there. Need for additional, this is not there, and reduces the blood loss to less than even 200 ml at times. I've actually witnessed it. And why wait for 500 when we can even lose less than that? It's like, having an open surgery over a laparoscopic surgery, where people at that point had so much of inhibitions and thought that, why waste so much time over a laparoscopic surgery when we can openly just go clamp the uterus and get it out. But today we know how a laparoscopic surgery gives the recovery, how minimal the blood loss is, and how the patient recovers so quickly. So we accepted it. So it is time for us to accept newer things. And I think all the CMEs, all the conferences are actually, focusing on these things now. Again, we know the different studies and the different societies that have accepted carbetocin with open arms. And so I would definitely thank the makers of Carby Act, which is carbetocin, which is the savior for all the women who unfortunately have to go through PPH. So let us save all these women and make it a better, better birthing experience for them. So over to you, Dr. Prashant.
Madam, thank you very much. It was very, very elaborate and wonderful. As you were saying, I remember I'm not an MD gynac, but during my medical days in internship, I have seen one case of PPH, and that was in the late 70s. My God, we almost lost the patient. It was so bad.
Yeah.
It was
so
really
Dr.
bad.
Prashant, it's like that, if you are in a rural area, if you're in a standalone unit, you have no choice, but sometimes you have to take over the surgical management of a hysterectomy. And they always say sooner than later. Why wait for things to go beyond your reach?
I remember I was an intern in JJ Hospital,
Yes.
That was that, yeah.
And in the best of the hands, things can go wrong, Dr. Prashant, because it is such a situation where you get, helter-skelter situation, where you're just running, you go into a fog. You don't know how to act. And that is the reason all these CMEs and these drills are so important. We may take it lightly, but the day we experience such a situation, it just helps us to quickly, respond.
Okay. But there are a few questions.
Yeah.
Can we say that can we use carbetocin prophylactically in every delivery?
Yeah, yes. Dr. Prashant, as I said, with newer molecules coming in, and I just spoke in my session that there is no superiority of carbetocin over oxytocin, or we are not arguing or debating on that.
No question.
But the efficacy that we are seeing, when we give oxytocin, we don't know at that moment why is it not working on the uterus. But nobody is there to challenge and see the drug at that time. So why not take such a drug which has already been, made in such a way that it is having its efficacy at a room temperature, right?
Yes, absolutely. Madam, even in the metros, I think maintaining a cold chain will be a problem, I suppose, no?
100%. So if you look at nursing homes, some of the nursing homes are, 30, 40 years old. They're still with an old refrigerator where the oxytocin is preserved. We don't even know whether the cold chain is maintained. So in such a situation, I would still prefer, why not a room temperature drug? Yeah.
Correct. And with all these advantages, especially the cold chain, the crux of the whole session is the best advantage is the cold chain, no cold chain required. Why is carbetocin now? What hinders the pickup of carbetocin? Is it growing up? Is it acceptance is good?
So I think the pickup is just because one is it's a newer drug. So as I said, there is always inhibition in your mind because you're so comfortable with certain drugs.
Right.
So using something new, such CMEs only can enlighten people.
Absolutely.
So I believe in such CMEs. Second is the cost. The cost of carbetocin is much more as you compare to oxytocin. But we have to realize that sometimes if oxytocin has not worked, in fact, I'm not joking that there are times when I have been using oxytocin or gometrin and then ended up giving carbopros. So imagine cumulatively, I'm spending much more.
Yes.
Right.
And there is always the risk of losing the patient, the most important risk,
Yes.
Madam, suppose it's maybe a hypothetical case. If you use oxytocin antepartum, maybe in the second stage, would you use carbetocin postpartum?
So there has been questions asked about this, and I think let's look at the half-life of oxytocin. We know that 2 to 3 minutes, and it lasts for 15. That's the reason we use oxytocin to induce and to augment.
Correct.
So I think if we can manage to give beyond that 15 minutes, the receptors again need, so maybe carbetocin will, but it's a good question. It is something that is debatable even now. Many people will say that oxytocin receptors have already been blocked. What is the role of carbetocin? Because they're similar.
In fact, people say that after, after oxytocin fatigue, we do not know whether carbetocin will work because they act on the
that
same
is something questionable. I think that study will be,
it will be an interesting study to do.
Yeah.
And how would you manage a PPH in patients with retained placenta, especially in the second trimester?
So if there is a retained placenta, of course, I have used carbetocin even in second trimester, and it has really given us good results. But if it is retained, there is no choice but to, of course, manually do it. So we need to take the patient to the OT. Then, the whole maneuver for doing it. Maybe we may require to give them, additional uterotonics. Yeah.
And even in preeclampsia, same thing would happen.
Yeah, definitely. So the safety of carbetocin in preeclampsia is also good, no?
Correct.
We cannot use other drugs, like you cannot use ergometrin in PIH.
Because of vasopressor effects.
Yeah.
Even misoprostol, etc., can give little blood pressure variation, being a prostaglandin.
Yes, it can, but misoprostol still has a safety profile over others. And it's this in respiratory, asthma and all is still questionable. So misoprostol is still not a comfortable drug for patients who have bronchial asthma and bronchitis. So that's what I'm saying. No, if you look at the superiority of this molecule over others, where it comes to, GI effects, where it comes to the cardiac effect, this has still a superiority.
Yeah, holistically, if you see everywhere, we accept the cost, everything is positive for carbetocin.
So if we look at a diclofenac over paracetamol, I am sure whoever is witnessing, we all are comfortable with the paracetamol. Yes or no?
Yeah, definitely.
So why not? When we give a paracetamol to any patient, I know I will not get a call back for any reason. Right? Very few can have a hypersensitivity to that drug. But if I give NSAID, I know that there may be a call.
You do not know. Yeah. Asthmatic attack precipitated.
Yes.
Madam, is symptometrin available in India?
Not really.
Not really. Yeah.
We are still not using as a combination in a while, but we use it as a separate.
And in your what is your preferred second line if oxytocin doesn't work? Is it methergine, it is misoprostol, or depending on cases?
So if I have used oxytocin and if I know this patient has no problem with the blood pressure and all that, yes, ergometrin is definitely my second choice.
Even with carbetocin, suppose you have to use a second drug, even methergine, I suppose, would be a better choice.
No, then with carbetocin, I have used ergometrin.
Ergometrin,
I have definitely used ergometrin.
It was really wonderful, madam. We have so many questions coming. In case we have any more, we'll definitely be in touch with you. Thank you so much for this lovely session, madam.
Yeah, I just hope
it was truly a CME. It was truly a CME. Even we learned a lot. Thank you so much.
I think I took too much time, but
no, it was wonderful. We didn't realize that. It was a wonderful session.
Okay, thank you. Thank you so much. Yeah. Okay.